Hello and good evening. Thanks for coming out to the Louisville Forum annual meeting. I'm Greg Condra, president of the Louisville Forum. Our program will run as follows. We are going to begin with presentation of the Fleur-de-Lis Award. This is where the Louisville Forum recognizes an individual from our community who really goes out of his or her way to help Louisville become a better version of itself. And I'm going to turn the microphone over to our Vice President, Tom Van Der Rostein, who will present the award.
Thank you, Greg. Good evening, members and guests of the Louisville Forum. My name is Tom Van Der Rostein, as Greg has said. I'm the Vice President of the Forum and the Chair of the Selection Committee of this year's Fleur-de-Lis Award. Since 1985, the Louisville Forum's Fleur-de-Lis Award has been given to a distinguished member of the Louisville community to recognize that individual's significant contributions throughout his or her career. And although each of the recipients of the Fleur-de-Lis Award over the years have been extremely successful in their professional careers and endeavors, the Fleur-de-Lis is awarded in recognition of those who have sought to make Louisville a better place through their civic, charitable, and nonprofit work. This year's recipient of the Fleur-de-Lis Award is just such a person. Since coming to Louisville in 1981, this year's winner has made a top priority to give back to the community through his service and contributions, with a particular emphasis on striving to improve education and to make it of the highest possible quality for our citizens. In the furtherance of this goal and commitment, he currently serves as the board chairman of the Jefferson County Public Education Foundation, the advisory board of the U of L School of Business, the board of trustees of Bellarmine University, and the Dean's Advisory Council for Fisher College of Business at The Ohio State University. He has also served on the board of trustees for Louisville Collegiate, the board of overseers of U of L, and as the chair of the Business Leader Champions for Education. He was instrumental in the creation of Hilliard Lyons Excellence Awards in recognition of outstanding teacher performance for Jefferson County teachers and administrators. These awards have been referred to as the Academy Awards for Teachers by local educators. And in recognition of these efforts to improve education in Louisville and Kentucky, he has received numerous awards, including the Joseph W. Kelly Award from the Kentucky Board of Education, and has been inducted into the Junior Achievement Kentuckiana Business Hall of Fame. In addition to his commitment to the local education, the Fleur-de-Lis Award winner has also served as the chairman of the boards of the following organizations: the Fund for the Arts, YMCA of Greater Louisville, the 2016 Metro United Way of Greater Louisville, the Louisville Downtown Development Corporation, and is the current chairman of the board of Greater Louisville, Inc. Finally, and definitely not least, while serving on these numerous boards and serving our community, this year's winner was raising a daughter with his wife, Missy, and was named president of Hilliard Lyons in 2003 and CEO of Hilliard Lyons in 2004. Therefore, it is with great gratitude for and recognition of his lifetime of civic service to the Greater Louisville community, it is my great pleasure and honor to, on behalf of the Louisville Forum, to announce this year's Fleur-de-Lis Award winner, Jim Allen. Come out here. Oh, wow. Ladies and gentlemen.
Look at that now.
Thank you. Thank you, Jim.
Thing's kind of heavy. Thank you. Well, thank you all for being here. Tom, thank you for your very kind introduction, and a big thank you to the Louisville Forum for this amazing award. I am sincerely humbled. As you know, we live in a time when civil discourse and thoughtful debate are increasingly rare. It's become easier to demonize adversaries than to hear what they are trying to say. Too often we are left with competing angry sound bites with no path to consensus. We need more bridges over chasms in so many areas of public discourse. And that's where the Louisville Forum provides a real service. Consistently, the forum brings to the podium thinkers, politicians, artists, and business leaders with dramatically different agendas. You present important civic issues in a safe place, then flesh out those issues with questions, discussions, and sometimes even with fresh solutions to difficult problems. That's why this award is such an honor for me. I've spent my entire career here in Louisville, and I've seen this city grow, change, and face significant challenges from time to time. But the active involvement of citizens who seek truth by airing important issues and ideas in venues like the Louisville Forum keep the community moving forward. Again, thank you. I am deeply honored that the Louisville Forum chose to recognize me as this year's Fleur-de-Lis Award winner. Thank you all very, very much.
And now to begin with the rest of our program, just a quick side note, if you're one of our panelists and you haven't yet got your microphone on, now would be a great time to go do that. Okay. So changing times, what's next in healthcare? We have three distinguished panelists with us tonight. First up is Joe Steyer. He's president and CEO and co-founder of Signature Healthcare, one of the nation's leading long-term care, rehabilitation, and healthcare providers with 125 locations in 11 states and 18,000 employees. Signature's mission and vision is to radically change long-term care forever through its three foundational pillars: spirituality, learning, and intrapreneurship. Under Joe's leadership, Signature Healthcare has earned many national accolades, including Modern Healthcare's Best Places to Work designation, the Inc. 5000 list of the nation's fastest growing privately held companies, U.S. News and World Report's list of best nursing homes, and many more. Joe's a Louisville native. After building Signature Healthcare for many years in South Florida, Joe brought Signature Healthcare's headquarters back home to Louisville in 2010. Also with us tonight is Russell Cox. He's been president and chief executive officer of Norton Healthcare since January 1st, 2017. He joined Norton Healthcare in September of 2000 as vice president of support services. He was appointed senior vice president, operations and development in October of 2002, executive vice president in September 2004, and executive vice president and chief operating officer in September 2005. In April 2013, he was appointed president and chief operating officer, and in 2014, his duties were combined under the title of President, Norton Healthcare. Norton Healthcare is the largest hospital and healthcare system in Louisville and the city's fourth largest private employer, about 12,000 employees. Norton Healthcare includes a network of 5 hospitals and 13 immediate care centers. Russ is a lifelong resident of Louisville. He has more than 20 years of experience in the healthcare industry, having also spent time at Caritas Health Services in Louisville, as well as Humana, Galen Healthcare, and Columbia HCA. Joining us is Yasmin Winkler. She's the Chief Executive Officer of the Central Region for United Healthcare Medicaid business. As CEO of the Central Region, she oversees approximately 30% of United Healthcare's Medicaid business. United Healthcare serves nearly 6.4 million Medicaid members in 27 states and Washington, D.C. United Healthcare is a division of United Health Group, the world's largest health insurance provider. United Health Group holds a mission to help people live healthier lives and help make the health system work better for everyone. Prior to her current role, Yasmin served as Chief Marketing, Product, and Innovation Officer for employer and individual at United Healthcare's commercial business. She has extensive experience in accreditation, quality improvement, business process development, marketing, product development, and innovation. Before joining United Healthcare Group, she held several positions with Blue Cross Blue Shield of Illinois, Texas, New Mexico, and Oklahoma. Yasmin lives in the Chicago area. At this point, I'd like to ask our panelists to come up and take a seat. Yasmin, we drew straws before the event and we put you in the big chair in the center, so hope that's okay. And so how about we give them a little warm applause to walk them up onto the stage? Yes? Good to see you. Thank you. So everybody's got your microphones on. They showed you where the on switch is. Okay, great. Okay, so to get us started off, I believe we're going to have opening remarks from each of you individually. And then if you want to do a little back and forth, that's great and encouraged. And we have questions from the audience. Okay? And did you guys decide among yourselves who was going to kick off?
Well, after hearing Jim's bio,
Yeah,
I mean,
Jim.
we can have Jim come up here.
Jim, great job. My people said, we haven't worked at all.
Yeah.
It's pretty impressive.
I was
Okay.
embarrassed he was reading my bio after that.
Yeah. Okay. Well, if it's okay, Russell, how about you start, and then we'll just kind of move this way down the stage, and I'm going to go grab my chair so I can see what's going on.
Well, thank you very much. And first off, I'd like to thank the Louisville Forum for your hospitality. I've never been to one of your meetings, but it's very warm, very friendly, and I appreciate that. I'd also like to thank the people who prepared and served the food tonight. It was outstanding, and let's give them a round of applause as well. My father told me many years ago something that you all have heard many times: blessed are the brief, for they shall be invited to speak again. I'd like to come back. I'm going to be brief. We talked about what's next for healthcare in Louisville. And as I thought about that topic, it just dawned on me the rich legacy of innovation that Louisville, Kentucky has in healthcare. And we are our worst critics and the least good promoters of some really unbelievable things that have happened in our past. And before I talk about what I think the future holds, I want to remind you of some things that Louisville, Kentucky has in its heritage around innovation, around risk-taking, and around success that we forget sometimes. Not a lot of people realize one of the very first pediatric heart transplants that took place anywhere was right here in Louisville, Kentucky at the Children's Hospital. There's a lot of people who forget the second artificial heart that was ever implanted was right here in Louisville, Kentucky. There's a ton of people who don't really understand that that company Humana was born and started right here in Kentucky with some nursing homes. There's quite a few people who don't understand that Kindred was born here. There's so many things clinically that have happened that are just wonderful. I mean, to think that Signature is here is quite a tribute to our city. So we've got a rich heritage of innovation. We've got a great legacy to be proud of. And I hope that we'll use that as a springboard to where our city needs to go in the future. And just some quick thoughts on that. I like to steal from articles, and Ken Kaufman wrote an article, he's a healthcare sort of consultant in the world. He wrote an article about a month ago about the last mile. And everything in every other industry now has encapsulated this last mile. How do we get the last mile done better and faster and more efficiently? How do we get something done in 3 clicks instead of 5 on the computer? How do we get something to your door in 3 hours instead of tomorrow? You know, how do we get food to you sooner? How do we make sure that things happen in a better and different way to make the experience that much better? Most industries have already dealt with this. Unfortunately, healthcare is just beginning to deal with this now. So what I think we're going to see in the future in Louisville, Kentucky is a much better, much more robust way of making that last mile more effective and more efficient and less cost. Just to give you some examples here, we really need to leverage the technology that's available to us in a different way. There's not a person in this room who didn't have the flu or know someone who had the flu over the last 60 days. And the access to get to a physician was compromised in this city at best. We were able to use video visits with people on a cell phone. They could actually phone in and have a video visit with the physician and determine whether or not flu was likely. And if it was, Tamiflu could be prescribed. But what we were able to do is to create access that otherwise wouldn't have been there. Plus the fact that nobody had to get in their car, nobody had to miss work, nobody had to mess with parking. And the whole experience took about 12 minutes on average. And in many cases, the copay or the charge was $25. So the best thing that I didn't say here was that you didn't have to come to a doctor's office, and if you didn't have the flu, get it from somebody who did while you were waiting. So the infection control side of what we do when we leverage technology makes a huge difference. But we have to work very, very hard to make that last mile a meaningful last mile and to still get a quality outcome. Everybody's read about what we call the new healthcare that Jeff Bezos and Warren Buffett and Jamie Dimon are going to come up with that is going to be revolutionary. 3 very bright gentlemen, they might just do that. But I think what they're going to find is the difference in what their industry is and the difference in what our industry in healthcare is that ours is just not a transaction with you. Ours is a lifelong relationship. We have to make sure that we find a way to be sticky with you and that we have a way to continue throughout your life a relationship that has great human interactions and that does make a difference. We're not a transactional business, only transactional from the standpoint of an appointment. But what if we were able to move along the spectrum in a way that you could schedule your own appointments, that within your own phone, within your own laptop, you were able to get an estimate of what your cost was going to be. You were able to compare shop what an MRI at this facility was going to cost versus what an MRI at this facility was going to cost. What if you could get the results 30 minutes after the MRI took place? What if your treatment plan could begin that very day? What if the follow-up visits could be done via video so that you didn't have to leave work? Now, this is just some of the things that I think you're going to see in the future of Louisville, Kentucky. But we have an incumbent responsibility as a major urban area in Kentucky to leverage this technology across the whole state. Because access to health care is a huge limiter. In the rural areas of Kentucky, we're not meeting the needs. And we have to figure out ways to be a lot more creative and to create that access in a different and more creative and unique way so that everyone can have the access and can have a situation where we can improve the outcomes and the overall health status of not just Louisville, Kentucky, but of the state. So very briefly stated, my idea of what the future looks like is a much more efficient, a much more technology leveraged, a better outcome, and a lower cost way to provide way more access than we are right now. It is not to our advantage for you to hear that you can't see your doctor for 7 weeks. That doesn't do us any good. It doesn't do you any good. We've got to figure out ways to be more productive with that physician and provider workforce so that we can intervene much more quickly and be involved in the wellness side of what you do and keep you from being sick. So I think we've got a great history of people who took risks and did things that did make the difference, from David Jones to Wendell Cherry. You can just go right on down the line. So many people have brought us here, but we've got a great platform to go forward to make it a much more consumer-friendly and effective future for us.
All right. So thank you so much for allowing an outsider from Illinois to come and join you today in Kentucky, a beautiful state, and one that I drive through a lot when I go to Florida, right? So I always Knoxville, or we're going through Louisville, right? That's usually kind of the way that it's been. But I have been in the health insurance industry for, at the risk of dating myself, 35 years this September, and started with a small startup HMO that was a public a demonstration with the Illinois Department of Public Aid at the time. And one of the things that I think I've seen is that change is something that has been very fluid from an insurance perspective. My children would tell you that they think I have the dullest job in the world, because when they think insurance, I think their eyes kind of cloud over. But the truth is that it's an incredibly dynamic field, and it's not just the insurance part, but the healthcare delivery system aspect of it as well. So when you think about how much medical technology has changed, and Russ and I have very aligned points of view with regards to technology and the role that it plays with regards to the healthcare delivery system. But whether it's medical technology or pharmacology, and think of what's happening, what's happened there, the miniaturization of all of the medical technology, when you think about what a pacemaker used to look like and what a pacemaker looks like today, it's incredibly different. If you ever go visit Medtronics up in Minnesota, you can get a real tour of what that really looked like once upon a time, since those guys in a garage invented that miniaturization of the pacemaker. So you have to think about how that actually applies then within healthcare beyond just what we typically experience, right? So some of the things that used to be the norm, like a doctor coming to your office, to your home, I remember that as a little girl, is no longer really the norm. Things have really changed, but I think part of what Russ talked about with telemedicine actually makes that a reality, just in a really different way than how you've experienced it in the past. So I think part of what I've seen with regards to this kind of continuous change that we've felt is the advent of HMOs in the late 70s and 80s, the whole idea of consumer-driven healthcare in the 2000s, all of Obamacare with regards to ACA. We're seeing now kind of the whole idea of integration when it comes to behavioral health and physical health and social determinants. Something that someone in Iowa, I was at a forum in Iowa last year, who said, when did we decide to separate the head from the rest of the body and decide that physical health and behavioral health should be separate? And there's really a move underway to make sure that those things are all integrated and that we're looking at people as the whole person, including everything that has to do with how they live their life, which frankly, from an insurance perspective, we typically are concentrating on that clinical aspect, which is really kind of 30%. The truth is that much bigger is the social determinants. Do you have a home? Do you have a job? Do you have access to food? Do you have transportation? Do you have childcare? All of those things that also actually combined make up a great deal of your own health as well. And we're going to see that there are states that are going to really kind of progress that. And never before have I seen Medicaid really be the juggernaut of innovation as I see it actually happening today. And in the past 3 years that I've been in this role, whether it's the requirements to be able to have behavioral health integrated with physical health and really act in kind of that singular way, or thinking about how we borrow from employer-sponsored care with regards to consumer empowerment and engagement. And at the same time, we have consumers, people, who also are demanding the things that Russ talked about, which is, why is it that in healthcare I can't have the same level of convenience that I have in every other interaction that I have, whether I'm buying or making a decision or getting education around something? It's really challenging in healthcare, but I can do that to buy a phone, to make my own car and order it, right? And buy it online. Like, remember the days where you went and you looked at the sticker and you didn't know what anything meant on an MSRP sticker? And now you know more than anything. You show up and you're really empowered as a consumer because you can buy that car and you know exactly what it costs, right? And how much it's going to cost you. That is that whole locus of the consumer really changing. So we see that there's going to be lots of progression with regards to that, and you're going to see it come through in terms of what states are going to really bring forth. So right now with CMS, there are about 22 1115 waivers. It'll be really interesting to see how that leads to experimentation and piloting, and I think we're going to see a lot of that. We saw that with Obamacare for sure. We ourselves have 3 CMMI grants that are all about experimenting, really to kind of continue to progress healthcare, not only in terms of bringing the technology along, but also to be able to do those things that Russ talked about. How do we get people access to care? How do we give them the best care possible? How do we do it just in time? And really being able to enable that. So I'm kind of excited about what does that mean, because really I've never been in this industry for 2 years running where something major hasn't happened. And legislation is really actually a catalyst for change when you think about it, when it comes to insurance and the healthcare delivery system. So we will see what the next kind of big thing is, but I think that you're going to see a lot of progression with regards to how do we make things better, but how do we make sure that the consumer is at the center of that. Thank you so much.
That was said, so pretty job, yeah. I never make notes because I always want to follow you guys, but first of all, Louisville Forum, always relevant topics. And congratulations, by the way, great award. But not to be redundant, because I think you made some great points. What we're dealing with today, Kentucky's got more healthcare bills in Frankfort today, Russ would tell you this, than in 10 years. And we've got the worst demographics in the country. And what I always talk about is we're so blessed to have, in the consolidation effort of healthcare, you look at Ben Breyer, Kindred, Jativa, we've had the best minds in the country start to consolidate here to keep the power here. And so I think it's been so important. Recently, we were in Fortune magazine as the aging care capital. First time Louisville's been seen that way in 30 years, right? But it's because the pioneering leadership that kept the headquarters here, people like Bruce and Ben. So I think Louisville's got enough intellectual property here and leadership to fix one of the hardest states I've ever seen. So we're in 41 centers across the state. And I always say Louisville should succeed as the 51st state, because the rest of Kentucky is very different than what we're doing. But I think the firepower today in Louisville and what the leaders we have, they can really fix the state with tough demographics. You all know today in Kentucky, we're in Frankfort right now. I'm in a business called nursing homes. Most people don't like nursing homes. And we understand today half our customers are going to be going home next 2 years. And our mission and vision has been everybody's got to have a home. My brother lives in South. I saw Deb Fair tonight. My brother lives at Deborah's building, raised a 54-year brain injury patient on Medicaid. And he's a guy you lose $100 a day on. But this Medicaid issue about that you do a good job on is where everybody's got to find a home. We're the poorest state, worst demographics, worst home demographics. And right now we have more bills in Frankfort today than we've had in the history of the state. But I would tell you this, I'm so impressed with the leadership in this region in Louisville that if I call Russ tomorrow, I call anybody on the SEAL Council, we're already coming together collaboratively to solve problems. I would think in the next 2 years, I bet you most of the leadership in Louisville is going to pave a way for 3 to 5 years out where Kentucky's demographic looks so different. So the reason why I moved back here was I was down in Florida and I missed the conversation. I grew up in Louisville. I was adopted out of St. Joe. I was a high school volunteer at nursing homes. When you're an adopted kid, you think about no one should die alone. Everybody should have a home. So my core roots were that service roots we have in Louisville and that compassion and empathy the city has. And so I miss being part of the conversation. So I said, send me back home where I got partners to talk about healthcare in a way that's bigger than City or bigger than me personally. So I do think right now, Russ, I'm seeing a spirit, I'm seeing it today in the city come together. But we've got a big lift in the state. We've got more issues going on right now. But I'm really confident that in the next 3 to 5 years, Kentucky's going to look so different as a state because of that kind of leadership. And I also want to thank this forum for this host of the conversation. You'll always have relevant topics here. We heard tonight, we come out and talk about healthcare, we're excited. It's what we do 24 hours a day. So thanks for having me.
Did you guys have things you wanted to ask each other? Or do you want to go
Oh, I've got a lot of questions for Joe.
All right, I'm glad I'm out of that.
Oh, no, you're next. The one thing, I don't want to tread into dangerous waters here, but I've never let that stop me. I was born in Pineville, Kentucky, Bell County. I had a conversation with the gentleman who is the administrator of the hospital in Pineville, Kentucky. It's a small hospital. It's probably 30 beds. I was born there. and it's the biggest employer. It's where senior prom is. It's where everyone goes to eat dinner on Sunday after church, and it's probably going to close. And it's not a different story in any other city, or rural community in Kentucky. And that's fundamentally wrong. And one of the things I hope that we're able to do in the future in healthcare is to figure out ways that we can provide access in a way that keeps delivery of care local, because outcomes are better when it's local. What's going to happen in Pineville, Kentucky is they're going to have a freestanding ED, and when you have a heart attack, they're going to stabilize you, and you're going to have to take your family to Lexington or maybe out of state. So I hope the innovation occurs where we're able to take existing facilities, retool them in a way to maintain employment, to improve outcomes, to make certain that it stays a local delivery product, if you will, if we can call what we do a product. But I think that when you talk about, and you use the term, keeping it local, I think keeping it local in Louisville is one thing, but keeping it local in the rural parts of Kentucky is something that we've got to really innovate towards and get better outcomes at a better cost.
And we're seeing things where Norton's is so known nationwide. So it's really about what Louisville is. If you go to San Francisco or LA for a conference, what's always neat about me is Ben Brower speaking, or everybody from the city's out speaking nationally. Russ agreed. Right. So you got the leadership. So eventually, Norton's may have to pipe in high-risk centers into that kind of hospital to keep it open. And we've got 148 rural hospitals here in the state. 78 are critical access. They're probably going to close next 3 to 5 years unless people like Norton step it up and say we're willing to provide triage services, teleconferencing, because those places need the service. I do think you guys are that pioneering to look at the state in a contiguous manner, because I worry every day. We're seriously got 41 nursing homes. We've got hospitals filed for bankruptcy, defaults every day. I was talking to Russ earlier. We're both in Puerto Rico right now, because right now Kentucky has the oldest, has the aging demographic. Our RN population is the oldest in the country. And so right now we're both in Puerto Rico doing recruiting because we can't find the jobs here in Kentucky, because we've had flat population growth. And right now we're down about 5,000 caregivers. So I'll tell you, he's in Puerto Rico, I'm in Puerto Rico, because if I raise my wages, so does he. And we're just short on supply and demand right now. So Kentucky's starting to go international, or Puerto Rico's US based, but starting to go outside of our own areas just to pipe in talent to be competitive. That's how short we are today. Any comments about that, Russ?
I couldn't agree more. I think that it's, we're going to have all kinds of creative solutions and do things differently. And, we had probably 75 nursing students from Puerto Rico spend the summer with us, and we were able to partner with Bellarmine and provide housing and classes and college credit for them, and they're a great partner. But where I was going to get in trouble a minute ago and didn't get in trouble, but I'll go ahead and get in trouble now. We've got a great opportunity in the state of Kentucky, and it's fraught with some peril. But the whole nation is going to be watching us with our 11-15 wave.
Oh, gosh.
We're first. And I kind of feel like Julie and Vicki ought to be up here on the stage, and we shouldn't be, because they know more about this than I do, for sure. But we're the first that's going to go through the process of how we implement this 11-15 waiver. You will read about Kentucky and Medicaid constantly in national publications over the next months and years. We've got a great opportunity to come up to aspire higher than political rhetoric and figure out the right way to serve 500,000 people who are on Medicaid in our state, and facilitate ways to keep them healthy and to treat them when they're ill, and to make them not have to be on Medicaid.
Right.
It's a great opportunity for us. I look at it very similarly to a lot of the innovations I talked about in the 70s and 80s. This is our chance in the spotlight. We can't blow this.
No, I agree that I think that all eyes will be on Kentucky as the first. I think we'll see how quickly the other 22 get approved, right, in terms of on the heels of that. But I think that you have the ability to not only influence what happens in Kentucky, but what happens beyond your borders, for sure. And I think that that's going to be a testament to the really good work that you have the ability to do here.
Okay, let's open it up to questions. We have 2 members of our board of directors who will be asking questions. We have, looks like first up at the mic is Dan Hartledge, and then we have Joe Marks. So, Dan?
If anybody has questions, feel free to just hold your sheet up and we'll come around and gather them and collect. I think maybe the first question out of the box would be for all of you maybe to sort of expound on the whole Medicaid question. It is an opportunity. It's fraught with risk, as you said a moment ago, Joe. It's political. It's white hot in this state. So maybe we can just go across the stage here, and each of you could kind of elaborate on what you see as the good and the bad, and still the mysterious about what's being proposed and what's going to happen down the road.
Well, that's a good one for Yasmin, don't you think, Joe?
Oh boy.
We'll go middle, left, to right.
You gotta love it. So some of what I see with regards to what's being proposed is really related also to, kind of borrowing from that employer-sponsored aspect of it, right? When you think about reimbursement accounts, being able to do that aspect of it, the work requirement piece. So that is, not that hasn't been tried before. We probably didn't have it in an 1115 waiver, but once upon a time in Illinois, there was a work requirement in 1983 for sure to maintain, being able to be on Medicaid. I think we're going to see a lot of tinkering to try to get to the right thing. And so what will matter is how well things get implemented, because that always sets the stage for whether people basically snipe at it or not. So if it's noiseless, then there's a modicum of success that goes along with it. If it isn't noiseless, which it'll be interesting, you will see that there will definitely be lots of eyeballs kind of saying, do we want to do that or do we want to do something different than that, right? And what kind of success gets attributed to it for sure. But I think it's a learning process for sure. And lots of times out of the box, and I can name many states that have been very progressive with their programs, the first year does not go so well. There are things, especially from a systems platform perspective, this requires a lot of systems infrastructure, a lot of tracking, a lot of data exchange, and so those will be the things to really look for to be able to guarantee some level of success.
What's great about Yasmin is that, when you work nationally, you see different things. In Kentucky, we've had it where a Medicaid person can't be home on a waiver historically. That's why this bill is very important to us across the board. We support Medicaid expansion 100% in our mission vision because everybody deserves a home. And right now, what we're starting to see, unfortunately, is a lot of people under 50, motorcycle accidents, drug overdoses in nursing homes. And it concerns us because it's a tough spot to be. My brother Ray's 54 years old, nursing home. He's trying to figure out what happened. So we're starting to see a younger population, and we still believe some waivers should be passed to get them back into other settings. We do think that, but I think in general, we're a state that's got some poverty levels. Usually, Russ, our lawsuits come out of Medicaid, people where we try to collect a copay or some kind of dual eligible, and we get sued a lot. So we're still working with tort reform, we're working with waiver liberation, we're working with some access issues, but we still support Medicaid expansion.
Yeah, the only thing I'd add is that, at the end of the day, we're all going to be judged on how we treat children, how we treat the elderly, and how we treat the infirmed and ill. That's our Medicaid population. It's astounding the number of children that are their care is provided through Medicaid. We can't get it wrong. It sets us back as a state another decade or more if we don't take this opportunity and get it right from how we execute on this waiver and how we implement whatever it is that we end up with. I'm pretty optimistic though, because I've been in healthcare. You were so kind to say 20 years. Actually, it's since 1981. They just hadn't changed my bio. It's just like, gosh, 20 years. I've been in 35 at least. I can't do math. But I go back to, I was working at Humana in 1983 and 4, and this legislation came out that was called DRGs, Diagnosis-Related Groups. And instead of hospitals and healthcare providers sending the government a bill and them sending us a check, the government said, we're going to pay you this much for a pneumonia. If it costs you more, you lose. If it costs you less, you win. And everybody ran around like the sky was falling. Healthcare is going to end. It's going to fail. It's going to be awful. Then we figured it out. You come along into 96, 97, we had this thing called the Balanced Budget Act. They cut reimbursement to all of healthcare by about 40%. Everybody ran around and screamed, sky's falling, healthcare is going to end, people are going to die. Well, we figured it out. So I'm optimistic that here we are again. We've got 500,000 at least on Medicaid. We've got a lot of children that are enrolled in that. And We don't have enough money. We know we don't have enough money. And we've got a lot of change coming, and we can't run around and say, the sky's falling, we don't know what we're going to do. We need to do like we've done in the past and figure it out. And I think we will. I'm optimistic. It's going to cause everybody to change and everybody to do things differently than we've ever done them in the history of healthcare in Kentucky, I think. But it's an opportunity. Well, we answered that question for you, didn't we?
Well, here's one to figure out. The questioner wants to know that, or says that addiction is costing us dearly. How do we structure health services to address this problem in a way we can afford?
Go ahead, Joe.
Well, I mean, I tell you what's really tough. The question is, like, we do drug testing, and it always breaks our heart that some of our employees can't get the job because of drug testing. Then we're trying to think, do we liberalize that rule? Obviously, government's people deserve second chances. But even today, we've had med cards stolen in Pikeville, where we've had people break into buildings and steal a med card on camera. That's how the addiction is so powerful today. And so, what we really, at Signature, we want to build a second chance culture. We've also now had to bring a lot of specialists into our healthcare centers because the treatment protocols have got to be so advanced to beat it. So we're doing more addiction center joint ventures. We may end up converting some of our buildings to addiction centers and do more joint venture campuses because the problem's that prevalent. And we feel like we've got to find a way to build some pathway to success. That's one of Kentucky's biggest liabilities that I think is a real problem for us we got to address.
I'm a huge proponent of education, always have been, and I think we're doing not enough early and not enough specific and targeted around the whole issue of opioids. I think we also have to retool our thinking as adults around pain. Some of these regulations that Joe and Yasmin are talking about, we lived with. There was a survey that went to every patient who was in our facilities that said, how was your pain managed? On a scale of 1 to 10. If we didn't get 10, our reimbursement was impacted. Okay, so that's not a good way to approach pain. With any type of procedure, there's going to be a certain amount of pain around healing. So we have to get away from the fact that any pain is a bad thing because we can't treat it that way. The other thing we can't do is we can't give people 2-week supplies of pain meds. And this doesn't make us popular with a lot of people when we say this, trust me. This doesn't make us popular with a lot of industries when we say this. But it's not, I keep telling people, in my opinion, it's not any one thing that's going to get us over the top of the mountain on this opioid issue. It's about 100 things done simultaneously, and it's heavy lifting. It's the most scary of any that we've had, at least in my career, because caregivers are afraid of being in the ED when somebody comes in with an overdose because the people that come with them know that we have drugs in that facility. It's a different environment than we've ever seen before around caregiving. We have people who get treated for the overdose and go back in the parking lot and use again and don't ever leave our parking lot and come back into the ED again. So there is no silver bullet on this issue, but it's one that has to be coordinated better than we're coordinating it right now.
I agree with Russ and his perspective. There's already legislation that's being passed in some states from a dispensing perspective where, post-surgery, you're only going to be given 6 pills. You're not going to get, I was sharing this story earlier today. I had arthroscopic surgery of my right knee in October. I got a 30-day supply of Oxycontin. I didn't use any of them because I actually don't find it to be effective for me. But my husband, who's a retired police officer, would tell you he could have sold those on the street for a whole lot of money. And so I think that it's a multi-pronged issue for sure. But the other thing, I think, is a perception issue. So it isn't just low-wage earners or Medicaid people that have addiction issues. It's basically cuts across all of our populations in the U.S. And it could be your mom who had a chronic back pain and was prescribed, Oxycontin, Vicodin. You take, name your poison and takes it every day. And the day that they don't take it, they suffer withdrawal. and withdrawal on opioids is actually a really horrifying thing. So people who go and get detox, it's not like detox for alcoholism. It's a very different thing. And that's how people overdose, is because when they do actually take it again, they OD on it. So there's an entire kind of study in relationship to opioids and what's led us here. These were a class of drugs in many instances that were intended to be a very progressive pharmacological advance, right? And here we are with an unintended consequence. That's really actually what's happened. So we have a national team that is working on opioids. We're working with a lot of the pharmacy networks as well. There are pharmacy locations that now are for disposal. How many of you have opioids that you were once prescribed that are sitting in your medicine cabinet that you don't really know what to do with them, right? So being able to dispose of them so that nobody can get their hands on them is another aspect to it. And when that happens, so I'll call out just one. There is a pharmacy network, a really large one that many of you know. They put kiosks in to do disposal. That is governed by the DEA. So they are not allowed to open that in any way or look to see who turned in anything or what was turned in. They have to take it to a place where they actually burn it immediately. So the laws that are layering on here are going to be really interesting. The problem is how do we make sure we don't go pit and pendulum where now people who are, have end stage disease don't have access to the drugs that they need with regards to, palliative care, right? So we have to be really careful about what the balance is too.
Those of us who live in Louisville don't think about this, but this past fall, one of our emergency room doctors at Norton Audubon noticed a trend that over a weekend, we were seeing a big spike. I mean, huge spike in overdose. And many of them were turning fatal.
That's what it is.
And he called a press conference quickly and basically said, something's going on. Don't know what it is, but something's going on and we've got to get a hold of this. If anybody's got any information, we need to know it. Well, long story short, it turns out there is a heroin that has an incredible amount of fentanyl in it, and it only takes a tiny bit of fentanyl to cause a problem. But it's going through our community, and it's branded as the Widowmaker. Here in our town. I mean, how it's branded for people is that this stuff will kill you. And the addiction is so strong that it doesn't matter. And it's just one of those things that you have to understand that has to be attacked from every angle possible. And it's not cheap to do that either.
We have several questions having to do just in general about private insurance premiums. They generally go up, rarely come down. Just reading the question here.
Payments to providers should go up too.
And so if each of you could just sort of comment, certainly Yasmin, I'm sure you had some thoughts, but just the whole issue of premiums, they go up. What's the future hold? And how do you wrestle with all that?
Well, so I think it'll be interesting to see how things progress with regards to how insurance is governed as we go forward, right? So under Obamacare, there were major changes to the medical underwriting rules. You know that, right? So preventive care is now something that's not disallowed, for example. So everybody is covered with regards to that. That changed all the actuarial underpinnings of insurance. And when you think about it from a pool perspective, part of what happened with the exchange is that you didn't have enough healthy people participating in it in order for it to actually do well, and there was no penalty that was really imposed for those people who decided that they were not going to participate. So insurance is based on the pool, often of the people who need care and the people who actually are healthy, like, knock on wood, my children who don't really understand why they have to pay for any coverage, right? So if you gave my kids and my daughter was texting me today for her open enrollment, if you gave her a choice, she would not be spending that $170. $170 a month, not so bad. She thought it was a lot of money because she could spend it on shoes. So, you have to think about that. in terms of who participates and who doesn't, and that does actually impact your premiums quite a bit as well. I think it's going to be really interesting to see, though, how this whole push of how do you put, it's a different part of this, how do you push people that are Medicaid today that are actually employed to receive employer-sponsored care instead, rather than being on Medicaid. So that's going to be another part of this that will have an impact with regards to premiums and who's in the pool and who's not. There's already one state that's potentially proposing that they actually cover the premium of the low-wage earner individual based on their getting their care through, or their health insurance through the employer-sponsored piece of it, to get them off of Medicaid instead. So it's an interesting question, because I think we're in this, there's a paradigm shift that's going to occur here yet again as we think about who's in and who's not and who has to participate and how they're going to participate. So I don't know that I have a real answer, except to tell you that we're in the state of flux, right? How things are going to progress.
And our comments is managed care's making too much money, and the providers are making too little, so it's got imbalance for a while there with a lot of things that City Chair probably lost $30 million last year, $41 million the year before. Been tough because the insurance rates are so low, to be honest. And so you see the stock valuations are way off base. What our concern today is, with Obamacare getting repealed, we want to get our employees covered, their families covered. So every time we spike premium, we lose our stakeholder base from getting insurance. So we're trying to find ways we can lower as an employer to reduce adverse selection. Our goal is to try to get half of people covered and their families covered. And with the loss of Obamacare, other options today, if you're not careful, it keeps shooting up because of adverse selection. And we're worried about anybody that works for us that doesn't have an insurance coverage plan is a concern to us.
So you're saying that there's adverse selection that happens because people go and they purchase care through, for example, the exchange, and then they may be healthy, and then they're not on your rolls.
100%. And then over time, it just keeps driving up, and then I get
Yeah, that's what I mean, right? It's not the same as it used to be 10 years ago, right? It's really different.
Covered it well. I'll let it go.
Not commenting.
Okay, transparency is a big buzzword today. But the lack of transparency in cost for drugs, hospital stays, and nursing homes and nursing home care is a reality. What are you doing to increase transparency with regards to cost?
Sure. So one of the things that I personally have worked on for, I don't know, probably 12 years, which I guess is sad to say, is the whole idea of how do we actually make cost something that is available to the consumer. The truth is that with managed care, and Russ and I were having this conversation, right, in terms of the HMO, once upon a time, I was on an HMO for 25 years. I didn't really ever look at a bill. I didn't really actually get a bill because I was on a capitated HMO, which meant that they were prepaying, the health insurance carrier was prepaying the provider that was my primary care physician, and whether I went there or not, they still got paid. And then when I did go, I didn't get a bill. So I became very immune to understanding what the cost of care was. And that's actually something that's happened in a pretty widespread fashion throughout the US. And I think it was an unintended consequence, right? Nobody really knows what care costs, so to speak. But today, with the advent of consumer-driven healthcare, which was really intended to kind of make that change of saying, well, now you're going to be subject to a $1,200 deductible, and you can put money in a health reimbursement account or an HSA, which will help you to defray that cost. And one is really a very probably the best tax advantaged account that we have in the US. But you first have to be able, other than preventive care, you have to meet the deductible to be able to get to that, right? So I think that we really have seen a need then to empower the consumer to understand how they go shop. But most consumers are reluctant because they really, at least this generation, we'll see what happens with the next generation, because I think that's really different. If you think about how my kids shop for everything, is really different than how we traditionally would shop for a doctor even, right? So that was part of that idea of how technology is going to be utilized in the area of healthcare. So today, if you're a member of United Healthcare, you actually do have access to our healthcare cost estimator tool, and it allows you to do the comparison shopping. So if you are referred for an MRI, Russ was talking about this earlier, you can actually look and see what are all of the places that are within whatever mile radius you want to select, or if you wanted to come to Kentucky to get your MRI, what would it cost there, and what it would cost out of pocket for you. And you would be able to take a look and see what and there's variation in cost. I mean, it's just a reality that we have for sure. So an MRI in one part of, in Louisville is potentially going to be different than an MRI cost in Lexington or in any other part of Kentucky. And that makes it confusing for the consumer because they don't understand what the variable is related to. Is it because it's higher quality? Higher cost equals higher quality? Is it because these guys are actually, they think they deserve more money and I have to pay for it out of my pocket first before I meet my deductible? So those are things that people want to know. So with large employers, as they really kind of embrace consumer-driven healthcare, they were trying to empower their employees to actually make better decisions in relationship to all of that, all of the care that you talked about. Probably nursing home I would put to the side. But when it came to procedure, preventive care, all of the things that you would normally think about, and we created something called the care path. So let's say that you were going to have gallbladder surgery, that you would know from the beginning of that medical event all the way to the end of it, exactly what it would cost you in total, what the total cost would be, what your employer would be paying for it, and what you would be paying for it, and how you would actually comparison shop for that as well. But you gotta want to do that. And not, it's not like shopping for a car or a cell phone, right? It's not fun. So it's about a medical event, and that's a really different thing. And you got to get people wrapped around the idea that they should shop for their care.
I think we've got to make it easier.
Yeah.
It's an incumbent responsibility of both payer and provider to make it easier and more understandable. And when I say that, we've tried to move to a system where before you have an episode of care, we actually have a conversation with you that says, this is what it's going to cost, this is what your insurance is going to pay, this is what's going to be left. How are you going to deal with that? Do you need help dealing with that? Do you have the resources? Before. Unfortunately, a whole lot of the care that we deliver happens on an emergent basis. So while someone's having a heart attack in your ED, you can't say now, Humana or Anthem or United, and do you know your employer number? And so we've got to figure this out from the standpoint of how do we standardize it? How is it information that you have on a regular basis that you can access in reference? But I want to also say transparency. Please don't lose the word transparency on just financial aspects. Make sure that you hold us accountable on transparency of quality data and outcomes. Because you need to know as a consumer, and I do think this is important, you need to know what the facility, what the healthcare provider that you're getting that service from, what his or her record is, and what their outcomes are and how they do. I would likely much rather pay more for someone who has 0 infection rates and back to work in 2 weeks. So I think transparency needs to be financial for sure, but it also needs to be quality and outcome.
So in our transparency tool, we actually have both cost and quality. Now, I will tell you that that's based on over 10 years worth of data to really create kind of the quality measure and then make it something that your average person understands, which, that's the other challenge, that's an aspect of it. The third aspect of it that is starting to kind of be brought in is the whole idea of the consumer rating. So if you shop on Amazon, right, you're looking for, I'm sure if you buy anything, right, you're looking for the stars. That's the easy way. But you might actually go into all of the reviews and you're looking to see what those reviews actually say. Well, guess what? That's what consumers, apart from what we might say is quality, they actually want to look at, see what people just like them who would go to this person to be able to get this kind of care or that facility, they want to know what you said about it. That's what they really want to see. And so there's more of that we're populating on our website through a company called Health Grades, but they want all of the editorial comments, which some folks might not be so excited about that being out there. But like I was telling Russ, I believe that many people, whether you know it or not, have Yelped their doctors, and there's a Yelp out there on, any one of a given amount of things. At least if it's my kids or my kids' generation, they put up Yelps for everything. little do you know you're being talked about, right? So I think it's really the way that it's going to be. It's kind of that open architecture that for sure has taken hold.
Maybe a two-part question for each of you. One being your thoughts in terms of the future of Obamacare, and 2, 4, 8, 10 years down the road, what's it going to look like? Is it still going to be around? And then the second part of the question is, what do you hope happens?
What was the second part? I'm sorry.
What do you hope happens?
Oh.
Well, that's real quick.
I think Joe got a shot at the last one.
Yeah.
So
Well, no. I think one thing that I think being in healthcare my whole life, healthcare wasn't a dinner table conversation. Today it's relevant everywhere. Everybody cares about it. Could change the election overnight, right? So being in 11 states, I just think there's Medicaid reform, an adoption curve that's going on in every state. There's different perverse incentives that are getting flushed out through informatics and transparency about the quality statements. So I think in Kentucky, our adoption curve's just slower because of some of the perverse incentives we got to take out. So I do think when we get down to, quality, access, affordability, I think Kentucky gets there for the Medicaid, underinsured that we need to address for mission vision. I think the federal policy stuff, we're still hoping that the federal policy will go to some kind of bundling. What me and Rush talked about earlier out here in the crowd was we're starting to see amazing collaboration. Used to be, I want to own that, I want to own this. It's like, no, I want to find a place that works. So we're seeing this new collaboration model. So we do think as they go to bundling or episodic care, just for care traditions across the country, we got to make it easy for consumers because the providers want to collaborate. They used to not want to. We were talking about a couple hours ago about people today want to collaborate. They want to share everything. They just want to get good outcomes and go home and feel good about it. So I do think if we can get some kind of federal reform that really bundles it properly and we eliminate some of these perverse incentives, I do think healthcare will be much easier to operate in the future and much more consumer friendly.
The whole term, to me, is kind of a weird thing of Obamacare. Where I sit on this is if we as an organization have the opportunity to interact with you at the appropriate level of care one time, we stand a much better chance of helping you take some personal accountability of your health going forward. I'm for anything, call it Obamacare, call it whatever you want, that facilitates us being able to have that interaction and intervention early in the process and gets you in with a primary care physician, gets you in with a provider, forms that relationship where you start taking personal responsibility for your health. If we could just get people in and do smoking cessation in this state, the cost of Medicaid or the savings of Medicaid would be astronomical. If we could just get those people who are dealing with obesity and diabetes in a treatment plan, we would save millions of dollars. So I hope it continues in some form or fashion to facilitate people seeking health care services, because I think the sooner we get them and their kids in a healthy habit of wellness checkups, of the proper diagnostics, checking for hypertension. It's not that confusing. It's not that complex. If we can manage diabetes, hypertension, in smoking cessation in the state of Kentucky, we likely would have a pretty good chance of saving or of funding what needs to be funded.
Okay.
So I guess I'm for it.
I think that, whether we call it Obamacare or whatever else we want to call it, the truth is that it did provide coverage for millions of people that were uninsured or underinsured in the U.S. And when you think about us as a nation and compare us to many others, including third world nations, sometimes we fall short there. So, in thinking about that, everybody in the U.S. actually deserves to have some level of coverage for sure, and should have access to care and the very best care that they can possibly get. Rural areas as well, which we're always trying to solve for, and it is a conundrum and really challenging. I think we want the opportunity to be able to bring our assets to like a state like Kentucky, when you have a really large organization that has a lot of acquisitions, a lot of talent, a lot of assets, and a lot of tools. How can we help to to think about that for the state of Kentucky or any other state with regards to what are the things that we bring that uniquely can position you to really meet the objectives that you're trying to meet. So that's kind of how we think about it when we're thinking about what does a company who's a Fortune 6, the responsibility that you bear when you have those shoulders. And you should be part of the solution all of the time.
Okay, well, I think we're going to wrap up now. I want to extend a warm welcome and a thank you to each of you for participating. I think we had a very smart, collegial, thought-provoking conversation, and I know I'll be talking about this tomorrow. So. We do have a speaker gift for each of you. It's a Louisville Forum Mint Julep Cup, so very Louisville. You can take that back to Chicago and enjoy that. And you can get a great mint julep recipe online, I'm sure. So probably. So as we wrap up, I want to thank everybody for joining us tonight and to encourage you to go online, make your reservations for our March luncheon meeting, where we'll be having a debate about whether or not Kentucky should legalize marijuana. So come join us for that. And we are adjourned, and I'll pass these out to you guys here. Thank you.